To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The PowerPoint for today's talk, an article related to today's talk is available for download from the dashboard. The recording will be available for review from our website tomorrow. Our speaker this evening is Peter Piatasik, who is a physical therapist with Select Physical Therapy. He received his Bachelor of Science degree in Physical Therapy in 1997 from Daemen College. He completed training at the Titleist Performance Institute and has been conferred upon as a Level 3 medical professional. He is also a certified Mulligan practitioner and a Select Functional Movement Assessment certified. He will be presenting this evening on golf-related injuries involving low back pain. And I'll have you take it away.
All right, great. So just real quick, I just wanted to throw a shout out to Dr. Henney and Mrs. McGrath for kind of hooking things up here and getting the ball rolling and putting me at ease that somehow, some way this would come to fruition. So I'm very grateful for the opportunity to speak to you guys about low back pain, and especially and specifically in the golf clientele, both amateur as well as high up into the PGA, LPGA, these type of levels. So anyways, next slide, Dr. Henney, if you would. There's the conflict of interest, just so we're on the same page. Okay, so just like Dr. Henney was saying earlier, just a little background. I'm a physical therapist with Select Physical Therapy here in Winter Haven. Certified Mulligan practitioner. And what that is, for those of you that don't know, they are manual therapists, but very functionally oriented. So for example, if you have somebody who has difficulty reaching behind their back to either wash their back, or if it's a woman who's trying to don or off her bra, or whatever the circumstances, they have very specific manual applications to improve that. And there are also applications all the way from C1 up high into your big toe for people that have bunion issues, bunionectomies, you name it. So later on this hour, I'll kind of bring everything together in terms of how it all fits together. And also selective functional movement assessment, which is very simply top tier tests. There's 10 of them. Which can be done in about 3-4 minutes, and each one of those has breakouts. And the power of the selective functional movement assessment is it really helps delineate the root cause as to what the golfer and or the patient, what the problem is. And they work very specifically with the Titleist Performance Institute, which is TPI. TPI is pretty much the gold standard out there when it comes to golfers, and you see these guys week to week winning on tour, and overwhelming majority of them have been seen out in their institute, which is in Oceanside, California, where I also did some training with kind of rare air, and we'll get into that too. But next slide. So just that's pretty much the synopsis there. I put this picture in because I think our clinic has the best full wall views in terms of real estate out locally here in Winter Haven. That is a picture off of the back of our clinic before I went home one night, and that's just phenomenal. Okay, next slide. Anyways, my visions are to, I like using evidence-based data, but, we do have licenses to practice. And I think people need to experiment a little bit and not always follow exactly every single thing that evidence-based data says. You have to dabble a little bit and try different things. But when you do that and when you apply the certified Mulligan techniques, we really can maximize functional independence. And also it parlays right into a lot of the golf stuff that we see day in and day out. Okay, next slide. So just a quick thing at the TPI, I'm not really plugging anybody in or, putting anybody on a high pedestal, but when you look at people who their whole lives have, committed to their vocation and whatnot. Dr. Greg Rose is one of the co-founders of TPI. He was one of the top biomechanists in the world, top 3, I believe. And then we look at Dr. Michael Voigt, who's probably our most decorated physical therapist. So these are the kind of people that, I was able to surround myself and study with for a little while. And they're part of this institute. So you start getting into some pretty rare air, and you really appreciate these people you work with just based on their experience. Wonderful people too. Their disposition or their whole attitude on everything they do is just so overwhelmingly positive. It just was so refreshing. But I just wanted to also indicate down that TPI, the Titleist Performance Institute, they have 5 disciplines. As you can see, it's medical, fitness, junior, biomechanics, and power. The 2 biggest ones are medical. That's where physical therapists, doctors, and chiropractors predominate. You have to have that degree to get into that specific niche and do your training. The other very popular one is biomechanics, and this is those that have degrees in engineering and whatnot gravitate towards that section if golf is their passion, and also teachers as well as juniors. Okay, but just a little bit on just who in the world is TPI. If you've never heard of it, just give you a little bit of insight there. Okay, next. So, and there it is. There in Oceanside, California, every day, 70 degrees, blue skies, low humidity. Next. There's their facility, state of the art. Everything is picture perfect. For those of you who do golf, they have the fastest greens on the planet, or at one point did. For those of you that are familiar with golf, they measure speed on greens with a stimp meter, and last I heard, they were the fastest. So just kind of a cool thing. But it's a golf mecca out there for anybody who's into golf and it's their passion. This is the place to work and study and become part of their group. Okay, next. All right, so going to just go over a few slides that just talk about just some of the literature. Some of it's recent, some of it's a little bit older, but still holds to this day. But one of the biggest factors when dealing with low back pain with golfers is their BMI, less than 25.7 kilograms per meter squared. But in general, what that means is what they're seeing is that kind of the heavier, stockier, shorter golfers have a tendency to not have as much low back pain as the tall, lankier, thinner golfers. And if you think about the body types, there'd be a lot more stress involving a tall, lankier, skinny golfer. That doesn't mean that anybody who's short and stocky is not going to have low back pain, but that's just a general trend, and that was in Evans, and that was in a while ago in physical therapy and sport. But next. So in another study with Lindsay, they talked about golfers without low back pain demonstrated over twice as much trunk flexion velocity on the downswing, which could relate to increased abdominal muscle activity in this group. In addition, it was also found that golfers with low back pain, they tend to flex their spines more when addressing the ball and use significantly greater left side bending in the backswing. We're getting a little technical here, but the important message with this article of Lindsay is predominantly when you have these golfers that can stay, it's a concept called staying plugged in. If you were to take an extension cord and you were to attach it to, say, the lower part of your chest, and then it attached down below into your saddle area, as you're coming into the ball and swinging the club, if that extension cord didn't unplug, that's staying, that's kind of what they call staying plugged in. If you look at other sports and you look at Roger Federer, incredible tennis player, if you see in a lot of his serves, you will see this increased crunch or flexion with his abs as he's serving the ball and through impact. If you look at pitchers, a lot of pitchers in the major leagues now, what you're saying is this, there's this crunch, or they're staying in this a little bit for as long as they can, where they're engaging their core. Now, core can be very misleading, and we'll talk about that in the end, but because I think there's a lot of misnomers out there. But bottom line is, when you stay plugged in, you're able to generate more velocity, but more importantly, you're not going to have nowhere near as much low back pain. So just interesting thought there. Okay, so I also talked about flexing your spine and having this low back pain at address. So go ahead, next slide. So there it is. You got somebody who is hunched over the ball. That's referred to as C posture. For obvious reasons, look at the back. You have an increased just flexion in general. The core is completely disengaged. There's nothing going on there. Okay, next slide. Another study, they talked about a retrospective cohort study. A lot of golfers they looked at, 703, so real nice sample there. And they talked about over 2 golf seasons. They were given a 6-page questionnaire. I just threw this one in, which was in Go Sugar, American Journal of Sports Medicine in June of, again, a while ago. The big thing is with golfers, there's the tendency, most of the injuries are repetitive motion injuries. You don't see as many single trauma events. So 82.6 reported involved overuse, 17.4 single trauma type of things. Something which you wouldn't think might happen, like getting in and out of a sand trap, that's quite steep. Tiger Woods, that was a classic example X number of years ago, re-aggravated his back. But now we're getting a little bit off track. But next slide. Okay, the article that I put with the presentation, it talked about, it's a good article. It's very brief, but it gets to the point, just how much force is put on your low back when you are golfing. And they talked about some equivalents, 7,500 newtons of compressive force. Well, what in the world is that in the downswing? Well, it's equated to about 8 times the average human body weight. And it's comparable to forces calculated for a football lineman when striking a blocking sled. So you can see there's a lot of stress which is put on the golfer and the spine. Okay, next. So I'm going to try to break things down to just kind of have some cohesiveness. Common low back injuries, disc dominate. For obvious reasons, the rotation, the compression, the side bending, followed up by facets, stenosis, degenerative disc disease leading to degenerative joint disease, which the article alludes to a little bit too, and then also the dreaded spondylolisthesis with the pars interarticularis compromise, and sometimes then the translation forward. Most commonly 4-5 and 5S1. Okay, next. So I just drew some images here, but lumbar disc herniation, bumping right into the nerve root, typically, based on the posterior longitudinal ligament. Next. Low back facet irritation, and in this diagram in particular, you can see where the facet would get irritated. If you think of the downswing, with your trunk, what happens in the downswing is left side bending gets replaced by right side bending. So you're side bending to the right and you're crunching down on the facet. So, and now we're talking about repetitive motion here. So you could see over time, a lot of injuries involve the facets as well as the discs. Okay, next. Stenosis as well, both central canal as well as intervertebral foramen, lateral stuff too. Next. And the classic degenerative disc disease progressing into degenerative joint disease. So as the discs lose their hydration, as we all know this, we start to get facet approximation. There's less wiggle room. The facets really start to get close together. And we see a multitude of changes, arthritic changes, spurring, and it's pretty self-explanatory. Next. And the dreaded spondylolisthesis, where we have the forward motion of one vertebrae on the other. I would kind of say this is probably headed into a maybe a level 2. You know, the pars has already been compromised. Now you're starting to get some slippage forward. So pretty serious stuff if it gets to this point. Okay, next. All right, so the next thing we're going to review is to understand how one hurts their low back. You first have to just understand some of the basic swing mechanics involving the low back. So, next. All right, before we go over the actual motions in the back, I think the majority of us are pretty familiar with this. We have Freyas Law, we know about the 3 of them, and we know the first one is that rotation and side bending occur in the opposite direction. And that is in neutral mechanics, or neutral posturing, or neutral spine. Now, we might be thinking, well, when you look at the golfer, when they're set up, they're bent forward, but that's accomplished by your knees being flexed and you're hinging at your hips. Back is still in a relatively neutral position. Yes, it is flexed a little bit, but still a relatively neutral position. Okay, so rotation, side bending, opposite motions with neutral spine. Next. Okay, I think we're missing part of the slide here, but I'll go through it. So with a right-handed golfer, as you can see in the picture, the golfer is going into its backswing. So what happens is you have left side bending and right rotation going on to draw the club back. As that's happening, you have extension going on in the back. So facet loading, this type of thing. Then conversely, what happens in the downswing is you have left rotation and you have right side bending. So here is where the problems occur. People typically think, well, it would happen in the backswing because you're, cranking back on your back. But in reality, the injuries occur in the downswing. And what happens is you have excessive or high velocity right side bending going on with your back. So you're loading the facet on the right side, you're clamping down on the disc on that side. And then you just repeatedly do this motion. So after a while, sometimes with some people, the system is bound to break down. Okay, next. Okay, I just thought I'd throw some pictures in, but these are just positions of the golf swing. What we have is at address, you have position 1, okay, or P1 or position 1, okay, next. And it goes all the way up to like 10 positions. P2 would just be the shaft is parallel. And then P3 illustrated here, you can see the left arm is parallel to the ground. Next, going into the backswing. Got right rotation, left side bending. And now P6 is now we're coming down in the downswing. The shaft you can see is parallel, and that's typically the position looked at before the moment of truth, or P7, which is the next slide. So go ahead, next. Moment of truth. So you're kind of returning back to the address position. Okay, just a quick thing. Why at address and also in the moment of truth is there this right side bending? Well, it's pretty simple if you think about it. Your right hand for the right-handed golfer is lower on the club than the left. Hence, you have right side bending. Okay, next slide. Okay, so modern day golf swing has a much more stable lower body with the upper body rotating on a stable platform. So in the article, they talk about the X factor, which I'm really not all that concerned with. But if you think about what's going on at L4-5, you know, you have your fifth lumbar vertebrae just hanging out there trying to stay stable, and then you have this rotation. So you have a ton of torsion, which happens and stresses the discs as well as the facets. Okay, next. So we talked about repetitive excessive side bending eventually will cause low back pain. It's not a question of do you have pain, it's a matter of when will you develop low back pain with excessive side bending. So this is the key. What you try to do is if you take a very long backswing and you have a ton of left side bending going on, it's just going to set you up for a high velocity, a ton in the downswing of right side bending. And this is the problem that a lot of golfers have. It just, I think the simplest way of putting it, it just accelerates the degenerative disc disease into the joint disease. It causes just a multitude of problems. One of the things then as a treatment idea is to train the golfer when he goes into his backswing of not side bending so much and keeping his right pelvis down so that he's not slamming down on things so much at such a high velocity at such a severe angle. Usually with golf, what you try to do whenever you're rehabbing a golfer is you try to you're always looking out for excessive motion or something they're doing, which typically then is what causes their pain. Okay, next slide. So look, that was a little bit on the kind of mechanics. Now we have, these are the top three things, low back injury inducing mechanics that we see. Reverse spine angle, S posture, and early extension. Okay, next. Okay, reverse spine angle. This was actually difficult for me to even get in this position. This actually hurts, but we do see this, and you can see what's going on. There's right rotation, ton of left side bending going on, just totally rear and back. And then what it happens is the upper trunk is closer to the target than like your hips and your pelvis. Next slide. So what we see is the torso is leaning towards the target. Pain is eventually created in the low back on the right side. And again, many think the left side would be injured in the backswing. However, the injury occurs on the downswing on the right side, disc and facet injuries. The torso is standing up too much, creating excessive extension, and then the golfer flexes and right side bends. So what happens is this is a recipe for disaster. Okay, next slide. Early extension. So early extension is, again, we talked about staying plugged in with the extension cord, which is attached down below in the saddle area, comes up towards your lower chest, and you want that cord not to get pulled on. You want to keep some slack there. When you don't, this is what happens, early extension. So you can see, as you're coming into the ball and you're extending your back, you're loading your facets excessively and way too early. And this was also difficult to pose for, but it's also what you see with a lot of amateurs, as they say. Okay, next. So at impact, the moment of truth, the low back arches and the facets are excessively loaded. It's pretty much just standing up too soon in the downswing. So it could be physical in terms of stuff going on, but it also sometimes can be a technical thing with the golf swing, in which they don't understand where they need to be as they're coming into P7 or the moment of truth, or as they're going to hit the ball. Okay, next. Okay, and then the last of the top three injury-inducing mechanics, S posture. So again, this was kind of difficult for me to get into this one as well, but what happens is you have your low back is arching too much. And if I were to take like a hockey stick or broomstick and put it along my back, if you looked down towards the lumbar lordosis, you would see some daylight in there. I didn't have a chance to get a picture of it, but maybe down the road. But that is referred to as S posture. So now we're going to start talking about the classic hip flexors are tight, the core is completely deconditioned, your low back extensors are tight, glutes are not, nobody don't even know how to fire your glutes or how that's incorporated. Okay, next slide. Okay, so this is what they call setting up for lower cross syndrome. Second most cause of low back pain. Suppose I didn't have my list in order, but again, inhibited abdominals and glutes, because what happens is the pelvis is rotating forward, and that's what the tight hip flexors and back extensors would do. And this leads to an increased lumbar lordosis. Again, overloading facets. Okay, next. So lower cross syndrome, and talking, this was just a really good descriptor. So what you want to see is you want your core and your abdominals kicked in. You want your glutes kicked in as well, because you're taking the pelvis, you're getting out of this anterior pelvic tilt, and you're getting it in a more neutral position. Worst case scenario is the low back extensors are tight, and then the pelvis is rotating forward because your hip flexors are tight. Kind of the classic, what they referred to umpteen years ago, lower cross syndrome. Okay, next. Okay, just a simple concept that the Titleist Performance Institute and SFMA and the powers that be, the trends and what's going on here. They talked about the concept of alternating segments, and we're talking about low back pain in this instance with this lecture. So your lumbar spine should be stable, relatively stable. Look at the bottom, lumbar spine is really 1 to 2 degrees of rotation per segment. That's very stable. If you look down in the hip triplanar, a lot of motion going on in a lot of different directions. You look at the knee, it's more of a hinge joint, flexion extension, although there's the screw home mechanism at the end for terminal extension. So there is a little bit of rotation, but overwhelmingly the joint is pretty much uniplanar. So they're talking about these alternating segments. So now you start getting up into the T-spine. Based on the orientation of the facets and how anatomically everything's put together, your thoracic spine is really built for mobility. But a lot of times what we see is that actually becomes hypomobile, not only because of rib attachments, but there's a multitude of reasons. So one of the things that, as you're going forward and you have your clients and you're working, whether you're a trainer, athletic trainer, personal trainer, whatever, one of the things to really be cognizant of is what kind of thoracic mobility do they have? Other thing I wanted to talk about just briefly was the regional interdependence. Super important. Concept, Vladimir Janda is a late physician and physical therapist, and just had the quote of saying the motor system functions as an entity. It is principally a wrong approach to try and understand impairments of different parts of the motor system separately without understanding the function of the motor system as a whole. What I take away from that is, you know, when somebody comes in and has an issue in one part of the body, just try to keep your mind open to, are there any other, you know, you always hear, umpteen years ago back in school, you look at a joint above and below, and it's so true. But now it's even being taken to another level, in that I'm starting to see literature and starting to see webinars of people who are pretty good, and you know, as physical therapists and what they do. For example, somebody who may have some left hip issues, one of the things they're going to start looking at, believe it or not, is the right shoulder. And what's caught between the two of them is your core. And why in the world would a left hip and a right shoulder be even remotely connected or have some sort of interdependence with each other? And a lot of times, it's, if you look at anatomically, the orientation of some of the muscle fibers, it's in the same plane. So crazy stuff, but crazy good stuff. Okay, next. Okay, so RSA, reverse spine angle, early extension, and S posture. It's, you know, these type of things, if you have certain swing issues or things that you're doing excessively in the swing, it's only a matter of time. If you exhibit one of these 3 different injury-inducing mechanics, it's only a matter of time until things are going to start breaking down and they have symptoms. However, as I stated earlier, with the proper training and the right people, and when you understand the mechanics, you can start working on things so that they can continue to play, and continue to play at a high level. Just a quick note, not going to use any names, but there was a golfer who was ranked in the top 50 in the world, and he was doing SFMA stuff. And, you know, we were looking at just simple top tier stuff, and it really didn't look good. But he didn't have any back pain. So, you know, you got to be careful, because you don't want to start introducing things, you know, which might be a little bit detrimental. But when you are in the off season and you see these type of injury-inducing mechanics, you have to approach these things tactfully. Yeah, and then once they understand, I think they appreciate you that much more. Anyways, next slide. Okay, so what in the world do you do? We all know how to take a good medical history, right? But just a couple of a handful of things to be kind of cognizant of as you're taking this history. How long have they been playing? Chances are the longer they've been playing, the more aches and pains and more different body parts are going to be involved. What age did they start? That's kind of follows right into that. Right hand dominant, left hand dominant. Some people are right hand dominant and play lefty and vice versa. So that's important to know too. Here's a biggie. If currently taking lessons, what are they working on? The swing coach, you know, if you're working on something specific and the player is trying so hard, sometimes it can actually become an injury-inducing mechanic. And just a quick thing, when it comes to the golf industry, the golf coach and his player, they are the head honchos. All the other ancillary services, the trainers, the therapists, the doctors that are on call, they are all part of the team. But in terms of, you have to have really good communication with the coach and understand, just so that you don't have any snafus when it comes to working with these golfers, because they have so many people, from psychologists to therapists to trainers to doctors. Adam Scott actually he brings his own chef with him when he travels. I mean, these guys got everything. So important to understand that. Also, a few more things in the history taking. What are their strengths and weaknesses? Most players don't spend enough time on their weaknesses. Practice sessions, super important. Have to emphasize to them, again, tactfully, it's not about getting your reps in, it's more about the quality of your practice. Maybe not hitting as many balls, maybe not hitting 200 balls when you have low back pain, maybe 40 or 50 with a very specific intent. When do they have low back pain? Setup, backswing, transition, downswing, impact, posting up at the end. A lot of times these give very strong clues as to where the mechanism of injury is coming from. Okay, next. Another couple more important things. Club fitting. You shouldn't be fitting to the club. The club should be fitting you. And many times we see changes in golf injury-inducing mechanics where they're trying to fit to the club, and that's completely opposite. Footwear. Some people have very flat feet, some people have very high arches, some people are tweeners. That's pretty important because ground reaction force is coming up through the body, ultimately being transferred to the club. They should be wearing the right footwear. If you have somebody like for me, I have extremely flat feet, I need as much stability as possible. So I would want something which is quite stable. Whereas if you have somebody who has a high arch, they almost essentially could be in sandals. Medication use during and after a round, very important. Also talk about food, eating, nutrition. For example, the concept of neural fatigue. You're coming up to the 16th or 17th hole. Where are your glucose levels? Are they low? Are they non-existent? Are you getting over a putt and things are getting a little kind of fuzzy? These are super important, especially later in the round. Obviously, tons of water. If they have to have Gatorade, that's great, but they also recommend cutting it. So maybe like a 50-50 type of thing. And then the last one, which is my favorite, is if I was a genie, what is the one wish you would like granted? You then start to go over with them just how realistic is this and what it's going to take and just what expectations are. Okay, next. So where to begin? In addition to, your traditional, range of motion, MMT, this, that, everything else, SFMA, like I said, top tier stuff, 3 minutes, 10 tests, very easy to do. From there, the SFMA has breakouts, which hone in and try to just help you and give you some guidance as to what is the root cause here? Is this a hip issue? Is this, poor thoracic spine mobility? Why does this person have low back pain? A lot of times the lumbar spine is working OT, and really it's T-spine and hips, which are the slackers, okay? If the overwhelming majority of people who come to see us, physical therapists, it's because they have pain. But if you do have somebody who has no pain, off season, although that really doesn't apply anymore because they have a wraparound schedule, off season or when things are not as busy, do a TPI screen, which consists of about 15 to 17 different tests. And that also gives us really good insight. Down there towards the bottom, we got FMS, which is predominantly used for most professional sporting organizations, NFL, Combine, etc., as well as like higher high school and collegiate athletes too. All right, that's good. Next. All right, just real quick, wanted to say this is kind of how everything kind of fits into my system. Selective functional movement assessment, Mulligan, which is doing mobilizations specifically to help these guys function and women function better. And with the Titleist Performance Institute having their specific treatment ideas as well as their evaluation methods, you can really kind of synthesize, and this is the stuff that I just love day in and day out, working with people. Even if people aren't golfers, SFMA top tier stuff is so revealing. I could just have somebody just do a forward flexion and immediately bells and whistles are going off in my head as to what really is going on here and what the problem is. Okay, next. So here it is, multisegmental flexion. This is one of the top tier tests. Keep the knees straight. What you should see, posterior weight shift, uniform spinal curve, which looks really good. She's able to touch her toes, no excessive effort, sacral angle, and minimum 70 degrees. So that would be what we refer to as multisegmental flexion. That looks really good. Okay, next. Another top tier test is multisegmental extension. Now, just looking at this quick glance, that looks pretty good, but I've got major issues with this. Yes, her ASISs are translating forward over her toes. Also, does she have a uniform spinal curve? No, she does not. And if you look towards the base of her back or towards the green portion of her top, she's hinging. And I know immediately, this is, I would say probably 99% of the time when I'm in the clinic, I'll just take my hand and put it at that level and I'll ask, is this where you have back pain? And they look at you like, how in the world did you know? And this is extremely common, especially in young female athletes. Other criteria, keep those upper extremities to 170, and the spines of the scapulae go past the heels. So really, she doesn't even get back there, and it's because of that hinging going on. And sometimes I do scrutinize a little bit as opposed to when it's not so obvious. Sometimes you have to do that. Okay, next. And then lastly is rotation, multisegmental rotation. Here we're looking at T-spine big time and pelvic rotation. No excessive effort. When you look at them from behind, what you should see is the opposite shoulder. You should be able to see it. So if you look at the patient on the right, you know, there's his left shoulder. So he's definitely getting past 90 degrees. So provided there's no pain, I would definitely deem this as functional, no pain, move on to another portion of the test. So those are just simple things with SFMA that really powerful stuff in terms of help breaking stuff down and extremely functional. Okay, next. Again, workers versus slackers. So a lot of times with the lumbar spine, root cause is actually above or below. T-spine, not enough mobility, should have more mobility. The joint is structured to be very mobile with the facets and their orientation. But sometimes too, because the ribs are attached, that can be an issue. And a lot of times with the hips, especially those that have this anterior pelvic tilt business going on, you start losing mobility, leading into FAI type of stuff, labral involvement, etc. So extremely important to look just above and below when it comes to the lumbar spine. Remember, lumbar spine, 1 to 2 degrees of rotation. Things typically go unstable if there's not enough mobility in the thoracic spine and with the hips. Okay, next. And just a little on my platform here, I'm talking about core. You know, it's very, people talk about the core and it's very, there's a lot of misnomers out there, at least in my opinion. Your core really consists of 2 different parts. There's a deep and then there's a superficial. Your deep core, without a doubt, you got pelvic floor, diaphragm, transverse abdominis, and multifidi or multifidus. These are extremely important. And if you just, the analogy to remember this, it's so easy. Just think of a can, okay? The bottom of the can is your pelvic floor. The top of the can is your diaphragm. And then you have your transverse abdominis and your multifidi. Superficial core consists of these internal external obliques, as well as fascia, latissimus dorsi, your glutes. The list goes on, and other structures which are debatable. Okay, next. All right, clinical pearls. So if there's anything I can just help you or I'd like you to remember, keep other body parts in mind. Be mindful of previous injuries as well. previous injuries, even after they heal, the overwhelming majority of regular patients and athletes will start to develop positional faults involving joints. Classic example would be somebody who has an inversion sprain. We see these all the time. Get an inversion sprain, or they have a distal fibular fracture. Things heal up, swelling starts to go down. They're sent for physical therapy. They're still having pain. Where are you having pain? Kind of towards the anterior portion of the distal fibula and a little bit in the gutter there. Overwhelming majority of time, it's usually indicative of a positional fault, and there's specific taping techniques that the Mulligan, certified Mulligan program does, where people have their taping techniques. We're talking literally millimeters of correction here, and it has a very profound effect on how the joints work, as well as reducing swelling and decreasing pain. So it's really good stuff. So important to make the correct diagnosis going forward, knowing your root causes. And another extremely helpful thing, if you're a athletic trainer, personal trainer, therapist, occupational therapist, whoever, it's important to be able to distinguish between a mobility and a stability issue. A classic example, we all know what a Faber test is: flexion, abduction, external rotation, involving the hip. Kind of figure 4 should see that knee come down. A lot of times people will not have the mobility. Well, they can't move it down. I got to watch my verbiage here. They can't get the leg down close to the table. Okay, so immediately one would think, well, you know, there possibly could be some labral issues here involving the hip. But there is another test out there called the stabilized Faber, where if you have posterior pelvic tilt, when you do the flexion, abduction, external rotation, a lot of times their knee will go way down. And, you know, that's kind of a little bit eye-opening. But when that happens, it's really not an issue of mobility or joint issue. This is a stability core issue, because they're not able to get their pelvis to posteriorly tilt. So that's just one example of mobility versus stability. If you did like a posterior pelvic tilt with the stabilized Faber and their leg still didn't go down, well, now I'm thinking there's probably something on mobility issue with the joint itself. Stability issue. Now, another example would be they lift their arm up 110 degrees. You get in there and can take them way further. That's an example in all likelihood of a stability motor control dysfunction. And then specifically with golfers, recommendations, always, it's quality over quantity. So what are you doing when you're working on the range? Don't just go out there hitting a bunch of balls or hitting 100, 200 balls, because the idea is to maintain and stay healthy so you can continue to play the game for as long as you want. And it's a little bit different than most sports, because a lot of guys play over decades, as opposed to, you know, somebody in the NFL who's only in for 3-4 years, or somebody who plays in the NHL. It's just grueling. I mean, there's very few players that actually go north of 10 years. So next. All right, and that's it. Those were from the articles earlier that we talked about. So just in closing, one more time, again, Dr. Henne, thank you so much. And Ms. McGrath, thank you for getting this into PowerPoint format. I was a little concerned because I had to switch over and do it in using Keynote, which a little bit of a learning curve, but all good nonetheless. Any questions? Is there anybody there? Was anybody there? Do you know? Or was it just us?
Oh, no, we had, looks like 84 people are currently here.
How many?
The first question comes from Amanda, saying a lot of your examples of low back pain with a righty was located on the right side. What are common mechanical issues found with left-sided pain in a righty?
You really don't see that many. You will see some on the left, but it's overwhelmingly on the right side. In a situation where people have issues on the left side, it could be because there's in the backswing too much left side bending going on, and they're loading the facets, and that just really can get irritating as well. So we talked about early on, one of the things to start training is kind of keep your pelvis a little bit more level in the backswing, just to kind of minimize your side bending on both sides. I hope that helps, but that's, yeah. Sometimes also you'll see people who have issues on the left side, especially when they post up or in their follow through, we'll see people have issues. Yeah. And there you really want to take a look at hip internal rotation on the lead side. That's huge. How would you help that? Show your feet out a little bit. And that's really the tip of the iceberg. Next.
Okay, Palmer asks, what type of acute fixes would you utilize during a tournament or an event? He asks about hip flexor, psoas release, glute activation.
Yeah, so typically what happens is when you get guys in tournament play, you got to be careful here. Again, you're part of the ancillary system, so to speak. It's the coach and the player, so you don't want to overstep your bounds. But overwhelmingly, what a lot of the therapy is you're not going to do anything drastic, but it's damage control, a lot of soft tissue work. And doing a lot of manuals on them. And then after the tournament's over, or when they get into that lull in the wraparound season, that's when that stuff needs to be addressed. But it's really, week to week, a ton of it is soft tissue stuff, which can be extremely effective in reducing a lot of symptoms, whether we're just strumming tissue, sustained pressure, even old school strain, counter strain type of stuff works good too.
Amanda with a question from before said, yes, thank you, and she'll have to ask him for a video. Jess asks, for someone who doesn't have SFMA certification, are there any resources to read up on for similar ideas to those concepts?
No, well, that's a good question. I'm not, I would actually peruse and go around and go on the FMS SFMA website. And if this type of stuff really appeals to you, then I would pursue it. And I say that this stuff is so powerful and it's pretty basic. It does get a little bit dicey with some of what we call the breakouts. But once you understand the system and the philosophy and everything, it's just fantastic. It's really worth looking into and at least maybe getting a level 1 certification. A little bit pricey, but whether you're working with golfers or not, you will use it across the board with so many patients. And there also is not only just stuff for your back, but it looks at shoulders, it looks at neck, it looks at balance. It's really good stuff. Hopefully that kind of helps.
Okay. Courtney asks, do you find that the athletes and coaches are receptive to the biomechanical changes that you suggest or make to these athletes swing, stance, mechanics, etc.?
Yeah, so again, got to be careful. Most important thing is when you're dealing with coaches and players is to set up a rapport, and you just have to be tactful how you approach things. You don't want to say this is the way. We're not trying to be confrontational. We're just saying this is what we're seeing in terms of injury-inducing mechanics, and I'm just wondering if this type of would help, and start to go over some of the anatomy and some of the things that we talked about today. That's probably the best way of addressing it. But are you going to be doing this right during the middle of a week or something when they're playing? Absolutely not. It's all damage control. It's all feel-good stuff, a lot of soft tissue work. But eventually, a really good idea to address in downtime. Yeah.
I'm going to wait and see if any other questions come in. And here's another slide up.
Dr. Henny, how many?
Yes.
Just curious, how many people were listening again?
I know at the time when we finished, there was 84.
Wow, that's fantastic.
Yep, predominantly athletic trainers. There's quite a few people who I see who attend regularly, and then some folks come for some and then watch us on YouTube later, and so certainly a variety out there. We had Nadine. She's already left, but she said great lecture, so we don't have any questions. She's a frequent attendee.
Nice, appreciate that. So does this this isn't going on YouTube, is it, or is it?
So yeah, so what happens is, for those who have any questions as they go through your questionnaire, and I can read through that, for those who are still with us, you are going to receive an email from GoToWebinar with the questions related to the VOC certification. So if they have any questions, sometimes they often reference back and want to be able to answer those questions correctly that you have previously sent over to.
Is that a like a private link that they get that only they can see, or is that just out there with everybody?
They get that as a link.
Okay.
All right. Anyone else with any questions? And if not, thank you everyone for joining us.
Okay.
All right. Very good.
Are we good?
Yep, absolutely. Thank you and have a great night.
All right, Dr. Henny, thank you.
Bye.
Bye.